And I'm going to hello, as people start to join us. I'm Romaine Johnson, and we have an outstanding panel today. I'm so happy that all of you decided to join us. I'm going to share my screen as I introduce our panelists. I'll give it about a minute before I start. And everyone should be seeing Ask the Doc, a conversation for people with idiopathic subglottic stenosis. And of course, if you also just have acquired subglottic stenosis, we will be talking to you as well. So happy for everyone to join us. We have an incredible panel. Okay, thank you. Maybe in the chat you can leave where you can tell us where you're from. I know we have Miss Anderson who joins us from Sydney, Australia, which I guess is about 10 a.m. your time. Is that right?
Yes.
And then we have people from the East Coast and the Midwest, and I'm from Dallas, Texas. Oh, wow. So we got Illinois, Nebraska, Utah, Hawaii. Wow. Ontario. We got people from Canada. Very nice. Someone from another person from Australia, several from Australia. Okay, good. Wow. We have an incredible crowd. All right. So it is about 6:01. So we're going to get started because we have about an hour. It may go a little bit longer. Obviously, we want to try to get all of your questions in, and we really appreciate you joining us for attending this webinar. First, let me thank the American Bronchoesophagological Association, including Dr. Seth Daly, the current president of the ABA, as well as the ABA Council. I also want to thank Charlotte Grill and Affinity Strategies for putting this webinar together. I am Romaine Johnson. I'm the Community Outreach Chair of the ABEA. I'm also a pediatric otolaryngologist who specializes in complex airway disorders, and I will serve as today's moderator. We have an incredible panel. Our first panelist is Catherine Anderson. She's a researcher and airway stenosis patient advocate, specializing in using the power of communities to drive insights. She leads the Living with ISGS Facebook support group. She joins us from Australia, where it is 10 a.m. Catherine, we are so excited to have you.
Hi,
Can you
thank
hear
you
my
very
kids in the
much.
background? And then next up is Dr. Alexander Gelbart. Pardon me, Dr. Gelbart. It is so great to see you again. I saw you in California. You were awesome, and I'm so happy that you're here. He's an associate professor in the Department of Otolaryngology at Vanderbilt School of Medicine in Nashville, Tennessee. He's the co-director of the Center of Complex Airway Reconstruction at Vanderbilt, and his research efforts include understanding the relationship between the patient's immune system in the development of airway stenosis, including ISGS. And as I alluded to, Dr. Gelbart was recently named the H. Byron Neal Distinguished Research Lecturer by the American Academy of Otolaryngology for his pioneering work in idiopathic subglottic stenosis. Next up, we have Dr. Alexander Hillel. He joins us from the great city of Baltimore, home of the 5-1 Baltimore Ravens and the Johns Hopkins School of Medicine, where Dr. Hillel is an associate professor. He also specializes in the care of patients with complex airway disorders, including idiopathic subglottic stenosis. Dr. Lell has a very distinguished research grad. He's an R01 recipient from the National Institutes of Health, and that is among the oldest and most sought after research awards in the country. And then next up is Dr. Laura Maturka from The Ohio State University, Wexner Medical Center. She's an associate professor, also specializing in complex airway and voice disorders. She is a co-member of the committee of which I chair, and she's also a member of all the important societies related to complex airway and voice, the Trilogical Society, the ABEA, the American Laryngological Association, et cetera, et cetera. All right, so our program will be about 60 minutes plus, and we'll have plenty of time for questions. We're going to start with a very brief presentation from each panelist, followed by open discussion and questions from the audience. First up is Dr. Gelbart. He'll give us an overview of the ISGS. Then Dr. Halil will talk about the role of immune function and microbiology. Then Dr. Maturka will explain current treatment options. And then Ms. Anderson will give an overview of her work with the ISGS Facebook. Whew. Dr. Gelbart, I turn things over to you.
Well, Romain, I really appreciate that nice introduction and the chance to talk with everybody. I'm feel really lucky to be on this panel and getting to talk to a lot of great people out there. And there's a lot of great questions. I really hope we can get to everyone's questions because Catherine put together a list and they're really superb. You get 3 academic surgeons together and tell them each put together a short presentation that could easily take 3 hours, but we'll all do our best to kind of keep it moving forward. So like, everybody knows, idiopathic subglottic stenosis is an inflammatory narrowing in the mucosa below the vocal cords. And we've really focused a lot on why this happens. So using both immunology and fibrosis research to build our ideas. And we've also really worked closely with Catherine and the group to understand the natural history of the disease. So most of what we understand comes from the clinical series, the small clinical series before, and then this big study that we completed a few years ago. You can see here, based on the histology specimens from our study, that it's really just a disease of the lining. So the cartilage of the trachea is fine. It's a mucosal thickening, which you can see in the pink on the right, that really is disordered in the disease. And so that's why a lot of treatments we have are aimed at improving the lining of the trachea. Some of the bigger surgeries we have were developed before we had good ways to replace just the lining by itself. But at its core, this is a disease of inflammation and scar, terms we group together in something we call fibrosis in the lining. And as you guys might know, being members of your group, most people are young, between 40 and 60, who develop this disease. They're nearly all Caucasian, although there are some other patient populations, but that's the vast majority. They're nearly all women. Most of the time, ISGS patients are really pretty healthy besides their airway stenosis. And they're all really pretty well educated and have a high socioeconomic status. You can see here the gray bar is the average socioeconomic status in the United States, and the green is the ISGS group, and you can see it's even higher than the average. So a lot of really otherwise healthy, smart people with this unique fibrosis just below their vocal cords. Interestingly, even though it's all Caucasian, it's not strictly genetic. So there are 20 families within our initial cohort, so giving a rough estimate of it being genetically transmitted about 2.5% of the time. And if you look at some of the big outcomes of the major treatment approaches, the surgeries, these are some of the results from that study. I know Dr. Maturka is going to spend some time talking a little bit about the details of the procedures, but open resection is effective at durable, long-term, recurrence-free treatment. That's the green line. This is 86 patients from a lot of different centers. Now, they were all pretty well selected, so it's not anybody who had this surgery. It's people who were probably ideal candidates. If you looked at endoscopic dilation, you could see over time, more and more people need another procedure, so that at about 4 or 5 years, more than half of the people need another procedure. And then interestingly, there was this newer procedure that we really were interested in, where you cut away the scar and you didn't dilate it with endoscopically, and then you use medicines afterwards. And that seemed like that worked better than just dilation alone. And so those were some of the major ideas that we had as far as the treatments out there. Now, how do those different treatments impact you as a patient? Well, CTR seemed like it had the most impact on your voice. But it was interesting that, even people who have dilation had a lot of complaints about their voice, even without the surgery directly affecting their vocal cords. We started to look to different elements of, where you live and what kind of financial situation you have. Do they impact how you do? Because for a lot of other diseases, they have a lot of impact on your treatment outcomes. And it doesn't seem like they really matter. Here I'm showing one about the average income for different patients, and there's really not a difference. So it really doesn't matter what your socioeconomic status or what your income is in terms of how you respond to treatment. We did see that higher estrogens seem to make the disease come back a little bit faster. If you compared premenopausal patients to peri and postmenopausals, it seemed like it was a little bit accelerated. It's a little tough to disentangle. Maybe the younger patients are just a bit more active and more demanding of their airway, but people always want to know, how does estrogen impact things? And so this is a little window into that question. So taking all the things we have together, what do we feel within NOAC pretty confident about? Well, there's a lot of localized inflammation in this mucosal scar. So we think that there's a role for host immunity in the disease. And Dr. Hillel is going to talk about that a little bit. Patients are nearly universally women, and estrogens associated with recurrence. So we think that estrogen is, and potentially progesterone, are part of both starting the disease or disease initiation and potentially progression. Two different facets. It mainly affects Caucasians in adulthood and clusters only 2.5% of the time, which tells us that it's not strictly genetic, but that genes probably have a role. And it's a complex disease where genes and environment probably interact to drive disease. And that's informing a lot of the ongoing work we have. Recurrence rates differ by how you get treated, as do treatment and quality of life. But it seems like the most durable treatments take away the affected lining. And it's primarily a disease of lining. And the social determinants of health don't impact recurrence rates. So there's a major role for the host biology, how you heal and how your body responds to how you do. So those would be some of the major insights I think that you guys have helped us understand by participating in the big natural history study we had. So really, this is trying to summarize and put together information you help collect and help drive. This is sort of how we think of the disease right now, where both genetics and estrogen play some background role and they interact with host immunity. And there's probably some sort of environmental trigger that acts on host immunity to help drive fibrosis. So these are all elements of the disease that we've come to understand in the last 5 to 10 years because of all the time and energy you guys have spent participating in our trials. And these are all different targets we have to try to address the disease going forward. Translational science, something Dr. Hillel is going to talk about, but I would put in a plug that culturally, I believe we're really going to have to work hard at rigorous kind of clinical trials to move the needle and really prove to people what different treatments work. And Dr. Hillel will talk about that a little bit. And I would just leave this with a little video that people put together for us when we first did the PCORI trial, just to really emphasize how grateful all of us as surgeons are and as scientists to have patients who are so invested in their own care.
We are breathing.
We are breathing.
We are breathing.
We are breathing better.
Better
together.
Better together.
Better together.
Better together.
Better together.
We're breathing better together.
We are 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 breathing better together.
So look forward to asking and talking and answering some questions. And I will turn the floor over to my esteemed colleague, Dr. Hillel.
Thanks, Dr. Gelbard, excuse me. It's a pleasure to be here. I'm going to pick up a little bit off of where Dr. Gelbard talked about localized inflammation, and then focus mostly on how we would translate potential immune modulators to a clinical trial by presenting the results of a survey that we sent out to the Living with Idiopathic Subglottic Stenosis group and received close to 600 responses. And that, I think, will help provide some information and should help guide some of the trials development that hopefully will come out in the coming years. So I'll start first with a histologic photo of ISGS, and you can see normal on the side with the tracheal cartilage taking up most of the image. But in the fibrotic specimen, we're not even at the depth of the cartilage. What I want to draw your attention to is this subepithelial inflammatory layer of hematoxylin cells, basically the blue staining cells, which are all inflammatory cells. And as we look at what those cells are, we're seeing that they're predominantly CD4 cells, which is a immune cell that seems to be directing the inflammatory response. I don't want to spend too much more time on that. What I want to focus on is how we translated that and how we're considering therapies that could target some of those immune cells, and what you as individuals with idiopathic subglottic stenosis felt about potentially joining a trial. And so we sent out a survey asking basic willingness to participate, a willingness to participate in a clinical trial with a placebo, a willingness to travel to participate in the trial, and then side effects common to immune modulators. And so what I'll show in these next few slides is a map of responses. And we receive responses from all over the world, concentrated mostly in North America, but a large number of responses from Europe as well as Australia. And just a map of responses from US states. The willingness to participate was high, close to 80%, when we looked at very likely or likely to participate in a clinical trial. We then asked about side effects, and the side effects range from common GI side effects to oral ulcers, peripheral edema, risks of infection, and then blood disorders. And as you can see, we got there was less interest in participating in a trial with side effects profiles that might include pneumonias or other infections or anemias or thrombocytopenias. Then there were sort of GI side effects or oral ulcers. And lastly, you know, when the NIH is asking for clinical trials, they really do want placebo-controlled clinical trials. And one of the questions we asked was willing to participate in a trial where you might receive a placebo. And we got close to 80% of respondents were willing to participate in a trial where you might receive a placebo. Similarly, willing to travel less than 200 miles to participate in the trial. Again, 80% responded in the affirmative. So again, early days yet, but it's another example of how we're collaborating together as we look for better treatments for idiopathic subglottic stenosis. With that, I am going to turn it over. Let me stop sharing. Romaine, can you remind me, Dr. Johnson, can you remind me, it's Dr. Maturka will be following me. Thank you.
Thanks, Andy. And thank you to all of you. I think just to follow up on Zandy's presentation, we all want to thank you as a group. I mean, you guys make up the most incredible community of research subjects. All the stuff we're doing, I mean, it comes directly from you and your participation in these surveys, and it's incredible. So thank you. So I'm going to quickly go through some of the management options. This is just really broad strokes. it honestly, it may be a little simple for some of you. This is kind of a sophisticated crowd, but I tried to make it not too technical. Just very broadly, I categorize this into 3 different areas, and one is office-based, the next is endoscopic, and then the third is open. You'll notice I don't include the Mattern procedure, the reacher. A lot of people are interested in that. And really, I tried to stick with the stuff that's been around for years that many of us do routinely. And you know, that I feel that we can really speak to a little bit more knowledgeably. And then finally, I'm going to go a little bit into medications. Those are all important parts of the treatment algorithm. So first of all, this maybe the lowest risk and maybe one of the most common ways that we treat this is with just an office-based steroid injection. And so here on the left side, you can see how we get someone numb. In my office, we usually have them breathe a mist of lidocaine first for about 15 minutes. And then, oh, that's the wrong one. And then you can see on the left side, a needle poke through there, and we spray a little lidocaine into the airway as that person exhales. They get even more numb. And then on the right side, you can see when we're doing the steroid, we actually try not to pop through, and we try to keep that steroid under the surface, as you see right there. So there's pretty good evidence that this is keeping people out of the operating room. They're sometimes done as a series of 3. And we've done some surveys on tolerance, and the majority of people who've had this prefer it, even though it is an awake office-based procedure. Most people would rather do it if it's an option for them. And then if even patients who have trachs, which is much more rare in your idiopathic group, there are ways to do it. And sometimes this is used by folks, I'm sorry, for folks who don't have trachs. And this is just using a flexible needle through the inside of the scope. And you can see this particular patient, you can see her trach there. The next sort of level up would be endoscopic management. And I know many of you have undergone this. So again, just broad strokes here, but this is a picture of the scope that many of us use, and this is what it looks like on end. So, you know, your mouth probably feels like it's much bigger after you go through this, but that's about the size of it. And then this graphic, I think is a little hard to follow, but this is the scope here, and then you see the endoscopic instruments going through the inside of it and down into this area of scar. You can see a little red laser beam. And this is a way that many of us do it, where we use this little platform to protect the rest of the trachea. And then we actually are excising some of the scar, to Dr. Gelbard's point, where, you know, some of the more successful approaches seem to be the ones where you're actually excising scar rather than just stretching what's there. And this is for many years the kind of the standard way of doing it, where you make some radial incisions and excise portions, but you also leave behind some little bands of more normal looking mucosa. And then a variation of this that we'll, I'm sure, talk about, and Dr. Gelbard already mentioned, is that rather than just making these little linear cuts, you can actually expand it to excise a whole portion, and you're leaving very small islands of mucosa behind. There's some evidence that maybe this is a better way to do it, and maybe even avoiding a balloon is good. The tricky thing is that those studies, as was mentioned, also involve a very specific medication regimen. So a lot of us are kind of, to be frank, kind of playing around with which of those elements we think is most important. And those are the things that we're all debating right now. And then finally, there's evidence that doing something at the end to prevent scar recurrence is important. And whether that's mitomycin, as you see here, where you soak a little pledget of cotton in this anti-scar medication, or injecting steroid, it seems that it may not be clear what's best, but doing something is probably better. So that's a lot of times the last step of the case, or one step of the case. And this is sort of an example of what you might expect in terms of opening it up, the appearance right afterwards. And then, as I said, I'm not going to go into maybe an intermediate option of the Reacher, the Mattern procedure, but finally, just to make something, to make the open resection extremely simple, for a lot of people, the narrowing is either right at this cricoid cartilage or right below it. We just literally cut that part out. And again, that excises that abnormal epithelium, which is probably why it works so well. Sew back together what's normal, and then you're left with a tight closure right here that you have to be really careful with for a week or two. And that's the broad strokes on management. In terms of medications, standard for many years has been proton pump inhibitor, inhaled steroid, and maybe Bactrim. Some groups have used Bactrim routinely, others haven't. You know, I personally have been kind of in between, where if I have someone with other features like nasal crusting or things like that, I've always used Bactrim. And there's been some recent evidence that's really compelled me to use it more routinely, and possibly we'll get into that. Some people will also put their patients on oral steroids or other antibiotics. Some people will do culture-driven antibiotics. Those are all reasonable options. And then longer term reflux management, whether it's with proton pump inhibitors like Nexium or Prilosec, maybe even with alginates, or seaweed-based therapies, or diet changes. And then again, Bactrim could also be used as a more long-term management. Okay, I hope that gives you just a general idea of sort of the framework of how we think about this. And I think I will now turn it over to Catherine Anderson, and I can't wait to hear what you have to add.
Thank you. All right, let's see if I can get this. Okay, is everybody seeing that? Good, excellent. So the Living with Idiopathic Subglottic Stenosis Facebook group, which is a bit of a mouthful, was set up 12 years ago. It started off as a little lonely me and gradually grew, and now we're nearly 5,500 members. I guess that the goal when I first set it up was to build on strength in numbers. My career for over 20 years has been in research and normally helping make more money for banks and telcos. But really for me, I was like, I need to know a little bit more information about the disease I've just been diagnosed with. And there really wasn't anything to find in Google. So the first thing I did was start doing research with members. So that goal for the group as a whole is to really keep the discussion fresh and solution focused. And those of you that are members of the group will know that I've worked with a lot of doctors around the world to create a rough guide for beginners, which we point everybody to, which really helps accelerate everybody's learning. So we are all up at the same level. And that talks about all the different techniques and the things that we've covered in presentations. Also just tips and hints for living on a day-to-day basis with this. So the group as a whole keeps it, rather than repeating the same old questions, we keep it moving forwards. And I work very closely with doctors, and a lot of you, the doctors on this panel would have received quite a few emails from me asking questions and checking facts, just to make sure that we're giving back the right information to people, and it's not led by inexperienced patients who, or just rumors. So it's a very positive culture, and we've had papers written about the group, really embracing that and what a good place it is for patients to be a part of. Most of our members are patients. We've got a good proportion, probably 3 and 4 are idiopathic, but we've also got people who've had intubation injuries or injuries from chemical burns and a whole lot of other things. We've also got people with idiopathic stenosis in different areas of their trachea as well. We have a number of supporters, so parents and husbands, children join us. And we have doctors, nurses, and students. We have a small number of parents of children who join, but the group really is about adults rather than children's care. Probably similar to all the other charts we've seen with a nice picture of the world. The group is predominantly in North America, Europe, Australia, and New Zealand. We've got a small number in South America, Africa, and Asia, but it really does fit the same profile as we've seen as a general patient output. So members get a lot of information from joining, and they can really take control. I think I asked people a few months ago, what do you get out of being members? And one of the big things was being able to ask the group all the questions that they don't ask their doctor. So being able to, ask for help, or, is what I'm feeling serious enough to go to the hospital, or is this normal or not normal? And really it's, a lot of people do get kind of shell-shocked when they go and see the doctor and the appointment's over so quickly that they haven't asked all the questions they had. So the group is a good place for them to do that. And it's safe. They can talk to people who know exactly what they're going through. And there's always good experience, and often local. We give them lots of advice on how to care for their stenosis on a daily basis. We get quite a few members who've had airway stenosis for many years, sometimes decades, and been coping by themselves. And as soon as they stumble across our group or join it, their doctor tells them about it, they suddenly learn all these different techniques to help them. So it's a great thing. The other thing is, it's because we are truly global. The people are on there 24 hours a day. There's always somebody there. And I can put up a post at any time of day or night, and there will be responses within, I think I've timed it at 30 seconds, someone will reply. So they're very engaged people. They're out there to help you. There's always a little bit of support or someone to talk to. They also get advice from other people who are local. So, where to go for particular types of treatments. For example, not all doctors do steroid injections. So some people might be asking where to go that's within their area. And there's always a bit of advice from people to help with that. People also learn things in this group that their doctor doesn't necessarily know. Not all doctors are created equal. So they can also help educate their own doctors, and we share medical papers and all sorts of things on the group that they can print out and take to their surgeon. And mostly that's appreciated, not always, but yeah. The group is a research group, which Dr. Matra mentioned, and a few other people, is a huge thing. I mean, we really see it as a research and support community. It's not just serving one purpose. Everybody wants to be part of the solution, and this is the ideal situation to do that. I don't think there's anywhere else in the world where you have over 5,000 patients in one place. So it's a great opportunity. I think surveys are generally getting up to, within reach of about 1,000 responses these days, so which is huge. I had a doctor quite recently do some research from out of London. Who said, "Oh, I'll be happy with about 70 responses." And I said, "We'll get 70 in the first hour." So, it was pretty amazing. So we're very engaged group of people, and it's great. We really get some solid results and good answers out of that. So it's a fabulous resource in that sense. And then I guess the other side that we see is that sense of empowerment. People understand what's going to happen. Not every doctor tells them the whole journey, what's it's going to be like when they have their first dilation, what's it going to be like when they get home. It's very simple, I guess, in that sense, that they can come in and they can go, right, I know what to expect. I know I'm going to have a sore throat. I'm going to want soft food. And it might not be instant good breathing. It might take a few days. Same with injections. You know, people sort of expect things to be very quick. And they have that confidence to be able to ask the questions in the group amongst a group of peers rather than talking to somebody else and get those that heads up. So yeah, it's a great resource, and I really say thank you to all the doctors who support it and make it the good resource it is. Thank you.
Okay, thank you. Sorry, I guess that was my cue. The talks were outstanding. I'm going to share my screen just to do this. Will start. Yeah, continue, and just to have everyone's face up. And so, hey, I also want to give special shout out to a couple of people. We have someone where it's 1 a.m. in the morning. Thank you so much for joining us and staying up late or early to participate in this. And I saw there was someone from Japan, and certainly a lot of people from the United States, as you mentioned. So it's the world is well represented. One of the things that comes up a lot on the Facebook group, as well as the questions that were asked in the chat and in the Q&A, is about reflux. You know, do patients have to stay on reflux medicines forever? Can they manage things with their diet? What do we really know what the role of reflux is in causing exacerbations of disease? Can you all talk about that?
I would field that just at the start. I'm very interested in everybody's view, but I think in general, in medicine, the more impassioned the doctors are about a particular point of view, you should interpret that as the lower the level of evidence. So there's a lot of people who think a lot of different things strongly, and I don't think there's necessarily wrong answers. I think the whole truth is, it's still waiting to get discovered. Different people do it differently in different places, and they take care of people safely that way. But I'm interested to hear Laura and Zandy, what you guys think about things.
Yeah, I'll pitch in my 2 cents. We did a survey recently on this, and we're still waiting to, well, I should say I'm still waiting to sort of synthesize the results. But I try not to be one of those people who focuses too heavily on it. But I do have a lot of people when I start to see recurrences faster than I want to, where I send them over for a pH probe. And I have a guy in town, and we've done enough now where we've got, kind of a setup where I go in and dilate them and he does their Nissen, and most of them haven't come back for more. It's a series that, we plan to write up, and it's still such a small series that it's not very meaningful. But that's the kind of thing that, we might be able to use the group to capitalize on. And I do think it's maybe a trigger for, some of the underlying issues that we know are there. I do think it plays a role for some of our patients.
Zandy?
Yeah, I think it remains to be seen. I think the prevalence of reflux in individuals with idiopathic subglottic stenosis is probably about the prevalence of reflux in the average population. When you look at some of the larger studies of, I think we can say that it's not causal of disease, and I think that is important to put out there. That there's no association of GERD with ISGS and in the larger series looking at ISGS and other etiologies. And I guess to answer your question, Dr. Johnson, I do think diet is really I've sort of come full circle, not just for my ISGS patients, but for all of my patients, from really handing out PPIs such as omeprazole or Prilosec to now pushing diet pretty hard. And I think that is probably the best way to manage reflux.
And is it just a reflux diet, or do you look at processed sugars or some of these other, dairy or gluten or what diet?
Yeah, I mean, I'm not, I think it all matters. I don't know that we're usually giving our recommendations for low acid foods, smaller portions. Those are some of the specifics of it, but I do think it's unique to each individual as to what their triggers may be.
I mean, I think there's a lot of room for, you as an individual patient to experiment a little bit with diet, certainly trying to be healthy, but trying different things and seeing, how they impact you in your life. That's one way where you can have some control over different treatments in probably a safer way. I would usually tell my patients that, just like Dr. Hillel said, that, there's a lot of men who get reflux, but there's not that many who get idiopathic subglottic stenosis, and that the prevalence of the reflux in ISGS is about the same as normal society when we measure it. So it doesn't necessarily seem like that's what causes the disease for everybody. If you have aggressive reflux disease, sure, I think it probably makes it mad in the lining, right below your vocal cords. But there's a lot of experts out there at reflux who can test and really tell you, yes, it's there, or no, it's not. And so if there's questions, I really like to have objective answers and say, hey, it's there, or no, it's not.
Are you using sort of multidisciplinary care? Like Dr. Maturka mentioned, she has a GI physician that she works with, or a person who can do a Nissen. That's probably not a GI person, but do you work with a gastroenterologist to do pH probe testing and impedance testings to see whether or not reflux is contributing to the patient's symptoms?
Yeah, at my institution, we have some really superb colleagues in gastroenterology who are really interested in how reflux can impact other things. And so we rely on them a lot to try to answer that question.
The other thing that a lot of the patients want to know is, how does hormones, what role does it play in the disease process? Obviously, it's a disease that primarily affects women. And, there's like, what is the relationship? Can you explain it further for our audience? Whoever wants to go first.
I mean, I think it's the best evidence that there's a role is that it's primarily women. And so that is one of the bigger differences between men and women, are, endocrinologic. So I think it probably has some role in how the disease starts. I have my own personal theories about how estrogen can impact things, which we're still trying to play out a little bit in the science realm. But there's a lot of other diseases that affect the airway, like cystic fibrosis or even asthma, that really vary by gender. And so women with cystic fibrosis get a lot more infections and die a lot earlier because of those infections. And that is really tied to their hormone cycle. So high estrogen means thicker mucus, means more infection, means, it's more severe problem. So I feel like we've probably overlooked, we think about this disease as surgeons, as trachea, as cartilage, and mucosa. And if we think about it more like pulmonologists or immunologists, maybe we get a different perspective. And it seems like estrogen really impacts mucociliary flow in the airway a lot. And so I kind of feel like that may be one way that it's driving things.
Does any of the, oh, sorry, go ahead, Dr. Maturka.
I was just going to share a couple of highlights from another survey study we did that I think we're presenting this weekend at our fall voice conference. But over 90% of our patients who answered were on oral contraceptives. and a quarter had early menarche before age 12. There's a few other things that maybe aren't quite as interesting, but this is something I think, we can expand on, not so much to prove the point, but just to kind of know which direction to start with. Maybe starting to look at some of the details of these trends. But that's your sneak peek.
Dr. Hillel, what about oral contraceptives? Do you think there's a role for them in treating the disease or making the disease worse?
I think the hormone balance I have seen in individuals, I've seen it shift dilation interval. And if we're looking at what are ways we can measure impact, it's probably time between surgery, and which is usually pretty consistent if the individual is getting the same surgery sort of time and time again. The dilation interval usually stays relatively consistent. And so I have seen it anecdotally in some patients who have, I had one individual who said, my dilation interval was every 2 years, and then I went on an oral contraceptive and I immediately moved to 4 years. So I think that's also anecdotal demonstration of the impact that hormones have on scar formation. But I think there is more work to be done as to the exact role that it plays, and how we can really leverage it to help those individuals with ISGS, which is really what it's all about.
Do you have anything to add, Catherine? Ms. Anderson?
Yeah, I was going to say, I worked on a paper a few years ago which looked at patients who were pregnant, and there was probably a good proportion of people who got worse during pregnancy. So they had already had it wasn't a stenosis that appeared or got discovered during pregnancy, they already had it and then became pregnant, but also a good proportion who got better and their airway got better. So it's, there's no rhyme or reason to this. It's sort of, you sort of think something's going on, but why do some people get better and some people get worse? And some people don't change. They remain as bad as they always were during pregnancy. So yeah, there's no easy, oh yes, this is it. It's kind of all over the place.
What have you all learned about mucus? Mucus plugs can be life-threatening. It's a big problem for this patient population. It's under-addressed by a lot of physicians. Do you have a standard approach? What are the tricks and the things you've learned over the years to help alleviate the problem?
I would add that it's a problem for a lot of airway diseases. So COPD, cystic fibrosis, asthma, that's a common complaint, so common that it's a major part of how they evaluate how well the treatments work. So I think ISGS fits into this fibrotic inflammatory disease in the airway, and it makes more mucus. That's one thing your airway does when it gets angry and inflamed, is makes more. And then the cilia don't work as well in the area of scar, so things get stuck. That's what I tell all my patients, is that they kind of get hung up right at the area of scar. So I've tried to adapt things that they've used in other specialties. So nebulized saline is a real mainstay to keep things moisturized. And then, I have people try Mucinex, which is the mucus thinner. Sometimes it helps, sometimes it doesn't. Those would be sort of the mainstays of mucus treatment across the board. It's a problem for other diseases, and there's not a clear solution that totally fixes it. So I understand that that's an issue, and I honestly think that's a big part of the disease, and it's probably some clue as to why it's happening that we haven't appreciated so far. But most people, I think, feel a lot better with saline nebulizers and staying hydrated.
The other piece, in addition to the sort of physiologic production of mucus, is the mechanical obstruction of the mucus. So the scar that forms acts as a ledge, and it just collects mucus, which is something we're regularly seeing when we are going in for a dilation. So that is the other piece. You know, I don't have much more to add to what Dr. Gelbard's regimen is. Sometimes hypertonic saline can work, and it's probably unique to each individual. And you know, if you feel that normal saline isn't working, there's 2% and sometimes even 3% saline you can try. I know that some people talk about mucomist, and I have not really found that to be very effective, and it's really rather expensive.
And smelly.
Yeah. Yeah, I've recently started doing the hypertonic saline, and the recipe, a lot of times I'll give to patients to just do themselves, even if they don't have a nebulizer. I tell them to stick it in their humidifier, and it's just 8 ounces of water and 3 teaspoons of salt. And of course, you know, you don't want to use table salt. You want to use non-iodized like sea salt. If that recipe's wrong, let me know. I think that's the right recipe. But yeah, I mean, I think just preparing patients for it. I sort of tell everyone they have to go buy a humidifier ahead of time, or let me help them, you know, arrange for a nebulizer before they even go to the OR. Knowing it's coming helps a little bit, but yeah, I mean, it's, you know, it's a problem.
Let's get a little bit into treatment. And so there's a spectrum of treatments. One of the things that comes up repeatedly on the Facebook page is people announce the number of dilations that they've had in their life. And so obviously a lot of patients, that's the only treatment that they're getting or consistently getting. And some of the questions are, is there something that, can I be a one and done? Can I have a resection, or can I have something and move on? How do you all make your decisions regarding when do I do a resection? When do I try laser dilations and steroid injections? And what can a patient expect from you in terms of those things?
Well, one thing I think is worth talking about is when you, before we move on to that topic, which is a great one, I would tell everybody that the biggest risk, I think, in this disease is the mucus plugs blocking your airway. We didn't get to talk about that at the end of the last one, but I would just tell everybody that that's kind of why you shouldn't let your airway get too tight and really not try to stretch it out, is because if it gets too tight, even a smaller mucus plug can block things up so you can't breathe. And in our original PCORI trial with 1,000 people, 4 people died of this disease over the period of study from mucus plugs, healthy, vibrant people. So, and I don't say that to scare people, but just to take it seriously. And that's why I would caution people, don't let it get too tight. Some people really like to try to stretch it out as much as possible, but it's probably safer for you if you are kind of on top of when your symptoms are declining and doing it before you're severe. I just say
That's
that.
interesting. And in effect, you're saying that if the mucus can be a marker when you need to come in.
Yeah, that's really what is life-threatening for people, is their airway gets tight and then a mucus plug, they can't cough it out.
We encourage people to measure their peak flow as well, and that's can help people understand at what level, when they're starting to go downhill, that's the time to start. You know, when it's a constant downhill trend, that's when you go and seek help. Don't wait till you're struggling to climb stairs and, you know, pausing for breath in between a sentence, you know, so.
And I think peak flows have been helpful, even just, that's something my office staff understands. And say I'm out of town and my nurse gets a call that someone's peak flow has dropped now into the 200s or under 200, you know, if she knows who that patient is, she knows, you know, I need to call her on vacation. It's okay. It's, you know, this one's warranted. And so it can be helpful for your whole system, you know, not even just for you as a clinician, but for the whole machine that we all try to build up to take care of you guys.
That's a great point.
Yeah.
What about, can we talk a little bit about dilations and then steroid injections?
you also had a good question about when to do what treatment. And I feel like it's just sort of different for everybody. There's a lot of variability in any group, and I think patients with this disease are no different. Some people like, I think, really the low risk, reproducible nature of the dilations. Some people, it really stresses them out to have to live with a disease that's going to need constant treatment, and they just need to wipe it off their plate so that they can move on with their life. And there's a different people, and they need different things. I try to talk to people, personally, when they come to see me, kind of about the different things you can do to treat this most of the times that I see them, sort of, option A, B, C, and D, so that they feel like they can kind of pick what's going to work best for them. And I think that makes people feel like they're in control of stuff a little more.
And I think it's important too to recognize that you're going to have a small group of patients that just does not respond to the dilations. And I think it's good to recognize that and just, cross it off your list. You say, okay, we try, or I'm sorry, I said dilations, the steroid injections. Well, it goes for both, frankly. But it's important for us as surgeons to be straightforward about that.
Yeah, I would agree with Dr. Materka and Dr. Gelbart. I think it's really a joint decision. I think we have the benefit of taking care of a large number of patients with ISGS and can share that information with the individuals when they're coming into our office. But really, it's laying out what are the benefits and risks, and then getting a sense of what that person who's sitting in front of you, ultimately it's really their choice, and providing that information really in a discussion. I do think, first, do no harm is a key tenet. And I think that's one of the things I would say why a dilation, it remains the mainstay, because it is a very safe surgery. And if I don't know where the balance is, where the tipping point is, as Dr. Gelbart was sort of mentioning for individuals, but if you have a dilation once every 2 years, is that for a safe surgery, is that sufficient for you with ISGS? The other big counseling piece that I have come around to, especially when I'm and it's really important, I think, in the initial discussion with an individual who has not yet had surgery, is these are healthy. You're all healthy individuals, and you don't have other medical comorbidities, and it's really hard to, I think, wrap your head around that. I think we all have that, right? And how we perceive ourselves. And now to have something that is really rare and affects you greatly, but the mainstay treatment is sort of a one where it manages it chronically. That's something that can be challenging to wrap your head around. And I think that's one of the real benefits, as Mrs. Anderson was saying, in terms of the support group of others who are living with this, can be really, really helpful.
In the chat, as well as in the Q&A, multiple people asked the question, how much is too much? How many dilations is too many? Is there any harm to keep going back? And then another person asked, is there, can we just define when we say dilation, do we mean just the balloon dilation and instrumentation? Are we also referring to dilation plus laser?
It's a good point, especially since many of us in recent years have maybe moved away a little bit from the actual dilation part of it. I think we're just referring to an endoscopic approach is sort of the safest encompassment of it all. And man, I mean, that's the question, is how much is too much? And one of the things I struggle with is, this is very much to Dr. Hillel's point, is that these aren't people who are going to be in the hospital otherwise. The idea of putting one of my patients in the hospital for a week to do an open resection, and she misses all of her kids' baseball games, and she comes out with a voice that's a bit deeper, and it's tough when even if it's a couple times a year in the OR, it's tough. It's tough to really push someone in that direction. And so, yeah, I mean, I guess I very much am, maybe my patients don't like it, but I'm not very aggressive about recommending anything. You know, I'll bring stuff up and say, okay, maybe now it's time for me to tell you more about this, but I don't really think it's the right time. But it's not my decision. It's really, you know, I'll only tell you if you don't have a good choice, if we have to do something, and I don't let anyone get to that point, you know, if they're staying tight with me. And I know you guys don't either. That's sort of the whole point of our management is we keep everyone managed at a point where the decisions are always going to remain yours, because you're not going to be on that edge where you're forced. So it's hard.
Anyone else want to? And then another question was, it's very related. How steroid injections? At what point is it just you're pushing the limit? Can there be side effects? You know, you've had one too many steroid injections.
Well, if water leaks out your neck when you're drinking, that's too many steroid injections. But short of that, I don't think anybody has proof that, you know, any excessive amount of them are bad or create a bad outcome. Same with the dilations. I mean, there's people who get a lot and move on to different things. There's people who get a few and move on to different things. I think it's pretty individualized. And there's, you know, some people who have gotten a lot of steroid shots and they feel like that really helps them. And I don't think them, you know, they're being managed by people who know what they're doing. And I don't think they're, you know, taking a step back in what they can do.
You know, I can also say, just to the audience, as a pediatric complex airway doctor, you know, I do lots and lots of dilations. We have some kids who become the adult patients of the people here, and it doesn't seem to cause major long-term harm. I know a couple of people in the chat mentioned how their airway would swell significantly after the dilation, and that is true. But I think long-term dilations and steroids injections are probably relatively safe. And so you shouldn't worry too much about it if that's what helps you get through the moment.
I don't think of it as dilation number, sort of absolute number. I really do think of it, and I'm seeing some of the questions in the chat, as time between surgery. And,
okay,
you know, when we get to less than a year is sort of where I'm starting to think it's probably really in that 6 to 8 months, though, that I will start discussing potential alternatives, because the concepts of those alternatives, either endoscopic or an open cricotracheal resection, is that, yeah, it's a higher risk surgery, but it's a higher reward, I think, as some of the data that Dr. Gelbard showed earlier. And if you're having 2 or 3 surgeries a year, in my mind, that's around the time that I will start those conversations in my practice.
Yeah, and I feel like, no, I'm just gonna say, I feel like as long as a patient, you know what you're picking between, and you know you're sorting through some of these options, I'm really supportive of people, you know, finding their path for stuff that makes sense to them. But that's what, you know, I think everybody in this room, Dr. Maturka, Dr. Hillel, Dr. Johnson, Catherine, have all spent a lot of time trying to give some sense of what you can expect with the different treatments in as much of an unbiased view as you can. You know, so for an example, the cricotracheal resection, durable, meaning that they, you know, I think a lot of people have that surgery when you're carefully selected, and then you don't need other surgeries after that, but your voice is worse after that. If you ask those people how's their life overall, they'll say, hey, it's a lot better. And is that because they've kind of come to terms with what the voice implications are going to be before they had it? Maybe. But I think just understanding your options and picking between them with somebody who does it a lot will make you feel like you're in control of stuff.
I was going to ask Ms. Anderson for her impressions so far.
Yeah, no, I agree with what everyone's saying. I guess what some of the fears I see in the group are, you know, if we have too many, is something else off the table. I think in the past, there were a few doctors who suggested that, oh, you could have too many laser dilations, and that would make it harder to do a resection and that type of thing. But I think that's less of a message that's coming out now. But I know in the early days of the group, that was a big issue. People talked about that all the time, that their doctor had said, oh, you can't have 6 dilations because it takes the other option off the table.
How do we raise awareness? One of the things that comes up constantly is, oh, they told me I had asthma, and 5 years later I find out I have this, this diagnosis, and that's 5 years of my life. What can the ABEA do differently? And then what do you all do? I mean, obviously we know what you do, Ms. Anderson, but what do the physicians do to try to raise awareness in their communities about this important disorder?
I'll tell you one just personal anecdote. I mean, besides giving talks and the things that I think we all do, I have found that when local, I guess not so local, but regional pulmonologists send me a patient who they send them usually for vocal cord dysfunction and they end up having stenosis, they're fascinated to talk about it. I've had a few reach out to me and ask if I would call them. And so I've actually started in my referral letters, giving them my cell phone and saying, hey, if you don't have any other patients with this, give me a buzz and I'll tell you more about it. And I mean, they eat it up. And it's a great, I mean, that's exactly who you need to know about it. It's reaching your target audience when they're looking for it. So that's one thing, that I recommend to a couple of our junior faculty members and anyone who's, looking to do outreach. I love doing that. And it's, you can nerd out with them on the phone, and I love that.
I will say, I think it is hard. I mean, we see this in another disease that we treat, which is intubation related stenosis, where we're not the ones putting in the breathing tubes, but we're the ones managing the complications. I give Dr. Gelbart a lot of credit for working to publish in journals that these other physicians who may see patients with ISGS will read, because they're not reading otolaryngology or ear, nose, and throat journals. And so I think that's one of the good ways to communicate to colleagues outside of our specialty.
That's a really good point.
One of the big issues we found is it starts at that primary care as well, because a lot of them won't be referring their patients. They'll be telling them to lose weight or take an inhaler for years and years, and they won't ever get to see any specialist at all, because they're just not being referred or not taken seriously at that level. I know for me personally, I saw 3 different primary care doctors before finally someone, took me seriously and sent me to have tests for asthma. And I was told, no, I didn't have asthma, but I was having panic attacks, which is great. Have a paper bag and a leaflet. Thank you very much. So it's you need to be quite, as a patient, quite tenacious in pushing for an answer. And not everybody is like that. And not everyone has the money, because it does cost money to keep pursuing new answers and traveling. So I think at that primary care level, it's going to be a challenge, because they are general practitioners. They can't be an expert in everything. And I think it needs to start there, that maybe it's a question, maybe it's something else. So, trying to target that lower level before it even gets to a specialist.
One of the things that came up in the chat is hoarseness, dysphonia. And the questioner wanted to know, does the injections, is that the reason why you're hoarse? Can you explain to the audience why patients who either have the surgery, but it's also just the disorder in general, why they have dysphonia? Many of them are hoarse.
I mean, I think it's complicated. A couple things. The conformation of the airway when you're doing an open resection, the hoarseness that you get after that, I think, is fairly predictable. But I think the hoarseness with dilations, especially if it's not just perioperative or just in the week after, that's I think harder to explain, and I think varies a lot on a patient-to-patient basis. I think the only thing I would say, with all of you being so good at advocating for yourself, if you have stenosis that's really getting up close to your vocal cords, I think it's important to switch the type of steroid you use. So when you're closer to the cords, I try to avoid using a particulate steroid. And so I'll switch from Kenalog to Decadron. And that's an issue for a lot of patients with this, that it gets up pretty high. What are your thoughts?
I think the voice, well, one, ISGS causes communication disorders, right? If you have a narrow airway, that's your engine for driving your voice. But I do think in some number of individuals, the scar does extend up to involve a vocal fold. Sometimes it involves into a cricoarytenoid joint, which is the joint that moves the vocal fold. And it can get tricky because it might be that your airway is further narrowed because your vocal cord isn't able to open. And the dilation sometimes also helps the voice in those cases. So it is unique to individuals. And I think it really does need to be, it's one of the reasons, I know this is one of the questions that was discussed, but I think it's one of the reasons why an otolaryngologist or an ear, nose, and throat doctor is really best positioned to treat ISGS.
Yeah, I mean, sometimes the voice, what people I think would report as voice trouble is the repeated coughing attacks from a lot of mucus or throat irritation. And so I guess the take-home message from Dr. Maturka and Dr. Hillel and I would be, it's a real part of your life, your voice. And if it's bothering you, asking about why am I having trouble when you're in seeing the doctor and what can I do about it? They, will help differentiate, hey, the scar you have actually keeps your vocal cord from vibrating well. And that's why your voice sounds the way it does. Or, hey, you just need to stay more hydrated so you're not coughing as much. Or, hey, we could get you voice therapy to learn how to have better breath support. Mm-hmm. They would be sort of individualized to you, but it's a good thing to ask your doctor about.
Would you say that nebulizing would help? Because I know people get mucus. It's obviously very thick, sticky mucus that gets stuck on their vocal cords as well. And that I would
certainly think it would help.
Voice hygiene. Should we have more multidisciplinary care? In the pediatric world, complex airway, we have clinics where we try to get as many different providers that are involved as possible: pulmonary, GI, social work. Should we be doing more of that in this population, considering all of that it's a life and threatening disorder, they're otherwise healthy? And one of the things that Catherine brought up was even involving mental health professionals as a part of our teams.
I think there's so many benefits to multidisciplinary care. I mean, a lot of what you hear us talk about today are ideas that we adapt and move from other specialties, whether it's, cystic fibrosis care or pulmonology or rheumatology or thoracic surgery. And I think within our specialty, we're really good at integrating different perspectives. I think multidisciplinary care really helps a lot. It gives you a lot of different nuanced views about how the disease is impacting your life and more ways to try to take care of it. Because I think it also shows you when you go to a facility, an institution that utilizes multidisciplinary care, it shows you all the doctors there have sort of checked their ego at the door a little bit and really are willing to listen to other people that they respect too, and that they really put the patient first because they really want to do whatever they can to help that patient.
Yeah, and I mean, I think unfortunately in adult care, it's rare to find a true multidisciplinary clinic, but it's not as hard to find a sort of I guess a virtual one, and I guess a plug for having again for having an ENT do it or someone who's experienced is that it's pretty standard part of our approach, I think, to, you know, cover the rheumatology aspect, sometimes even pulmonology. There are other actual lung issues, of course, GI or reflux. And I think that's sort of the point of having an ENT involved, is that they sort of understand that there's probably going to be some other people to pull in, or at least some other testing outside of just strictly the airway testing that needs to be done.
Where's your research heading towards? Where do you hope to be 5 years from now, 10 years from now with this disorder, in terms of surgery, in terms of our understanding of the immunology, the biologics, the microbiologics? Can you give us some insight into what you're envisioning when you go to the lab and you start working on these things?
Dr. Hillel, you want to field that?
Sure. I will say broad brushstrokes. I think we hope to have clinical trials addressing ISGS. It's and I think working with the Living with ISGS group is a great collaboration to do so. Our hope would be, trials are expensive, and our hope would be to find funding to do so, to test some of our immunologics that we are having success with in our translational science labs. The other piece that's actually interesting, and Dr. Gelbard had a slide that addressed it, is the concept of the epithelial barrier, which I think to this point had probably been ignored to some extent. But now that we have some big data techniques that allow us to look at where are the abnormal cells and what are the abnormal genes, they are pointing us towards the epithelium in ISGS. And I do think that is a new horizon for us. It actually fits in with some of our treatment strategies, which is why when we cut out scar but leave some of the epithelium in an endoscopic resection, or I know some people talk about the Mattern, where we're actually cutting out scar and replacing the epithelium, why those may work. So I think that is that is one of the areas that is going to be very exciting to explore.
Yeah, I totally agree. And I think that that picture that we try to paint of there's multiple facets of the disease, where the immune system is one part and the epithelium is another. There's probably different kinds of environmental triggers, and there's probably different kinds of disordered wound healing. And so, you know, those are all things that we can try, you know, to address. There's a lot of drugs for each one of those, and it, you know, really proving that they work or showing you guys that they help is harder than it seems. You know, as surgeons, we do things sort of as master craftsmen in our own shops most of the time, and people are really good at what they do. But I think we're going to come to the limits of that approach, you know, in our lifetime. And I think that real progress is going to need, you know, just like Dr. Hillel was saying, these trials and finding ways to do that kind of effectively, cheaply, and even within your group remotely, because so many people are spread so far apart, is going to be a real key to the progress. So I honestly think that as patients, you know, remaining advocates and being enthusiastic about, you know, well-designed, participating in the design of good clinical trials, I think is going to be essential to progress. It's going to not necessarily be a lightning bolt that fixes everything, but it's slow and steady progress, kind of inch by inch, you know, year by year, we make treatments work better. I think that is sort of how I see the next 5 to 10 years. I'm really excited about all the things that we can target, and a group of engaged patients that wants to prove that those things can work.
I'm also in touch with some doctors in the UK, and I know that there's definitely some work going on in growing. You know, I don't know all the technology behind it, but it's about growing mucosa. So sure. a chance for the future to be able to improve on some of the techniques, such as the Mattern, which remove the layer of mucosa at the moment, but be able to replace it and replace the scar tissue with new airway skin. I guess that's
Yeah.
kind of in the early
Great.
stages at the moment, but I know that's quite exciting for our disease.
Yeah, regenerative medicine is very exciting. We have a few minutes left. I wanted to end on a couple of, obviously I'll give each of you the opportunity to just say some final words, but two things that came up. One is homeopathic medicine, homeopathic therapies, alternative therapies. What are your thoughts about the things that people have told you they've tried and worked, haven't worked? And then lastly, several people have wondered about the effects of COVID. And have you seen any patients who have ISGS and have gotten COVID? What are any thoughts regarding that?
Just,
Oh, yeah, go ahead.
no, after you, Dr. Maturka, please.
I think what I would say to those ideas, I guess one thing is that my understanding of homeopathic medicine is that it's a very specific, it's not a term for alternative medicine. You know, it's the use of very minuscule amounts of different sort of essential elements. And I've not seen anything in homeopathic medicine that I got real excited about. It doesn't mean it's out there. It's not out there. I just haven't seen it. But a lot of, it's crazy to me that this is considered alternative, but a lot of the diet-based things and some of the anti-inflammatory approaches, it's crazy to me that that's not a fundamental part of Western medicine, but it's not. And I very much believe in a lot of that. And, you know, the way we treat reflux and the way that's evolving, I think is a really good example of that. And I do think that some of the anti-mucus diets, that's how I think of them. They're termed a lot of other things. I think there's absolutely growing evidence to support it. It's not just that you get a lot of patient anecdotes. You get those too, but finally we're getting some actual research behind a lot of it. So I think most of us are moving in that direction, you know, as long as we can see more evidence about it.
Okay. A couple of people in the chat mentioned COVID and concerns. Obviously, we're all concerned about COVID infections. Have you had any experiences with any of your patients or?
You know, I was really fascinated to see some of the things in the chat about patients with ISGS who got COVID and then have felt a lot better after they recovered from COVID. You know, I could think of a lot of reasons why that might be. The, you know, immune response that's in your airway when you get COVID, maybe. It's an interesting question. I guess sort of on a tangent to this topic is, you know, I know Dr. Maturka and Dr. Hillel and probably Dr. Johnson too, we've really been besieged by people with airway problems since COVID has started. These are all people who had to have a breathing tube in for a long time when they were really sick. So, you know, continuing to advocate in your group and offering patients who maybe don't have idiopathic stenosis, maybe have problems that developed after COVID or breathing tube, I think is, you know, a really vital outreach that you guys can help with, because there's a lot of people, you know, they were sort of frail a lot of times and sort of sick before COVID, and then, you know, have really had problems with their airways after.
Yeah, we've had quite a few people join who have had COVID and been intubated, including several doctors who got sick, who were working in ICU and then caught it and ended up in ICU themselves. And I think, you know, they have particular needs and particular emotional needs. It's quite different. But yeah, everybody's welcome into our group, and we give them our advice and help in that sense. So.
Okay. All right. Well, we'll start with Dr. Gelbart and Ms. Anderson, then Dr. Hillel, and then Dr. Maturka. We'll have you give your last words. Dr. Gelbart.
I would just say that, you know, as a group of patients, like everybody else has said, you are a fantastic group of people, and there's a lot of doctors out there who are really committed to trying to help you get better, and you're doing great things by asking hard questions about how best to take care of yourself and supporting each other, and it's really impressive.
Ms. Anderson.
Oh, I'd say thank you so much to Dr. Johnson for reaching out and for organising this. This type of event is rare and incredibly valued by all patients. We really don't get the opportunity to be able to hear from experts, and if we could have something like this on an annual basis or something like that would be amazing. So really, really appreciate it, and thank you very much for inviting us.
Dr. Hillel?
Yeah, I would just say it's really a little bit of a tangent, but it's more of sharing my feelings. I have to say, working with the Living with ISGS group has been one of the most rewarding aspects of my career, to work with a group of patients, to play a small part in some of those individuals' health, but the opportunity to collaborate and to learn has been just an absolute joy.
Dr. Maturka?
It's just a big mutual admiration society. Yeah, I mean, I'm just so impressed with this group of patients, as I mean, you guys really have moved a lot of this forward yourselves. So thanks for inviting us. Romaine, thank you. You're a great moderator. And I mean, thanks to everyone. Just hugs and smiles all around.
Yes, thank you.
Well, once again, I want to thank our panelists. I hope you and the audience really enjoyed it. Thank you for joining us. This session will be recorded, so if you go to the abea.net, our website, hopefully within the next week or so, we'll have it up and you can rewatch it. And we're going to take you up on your offer, Ms. Anderson, and we're going to try to keep this train rolling, come back periodically and talk. I'm Romaine Johnson. Thank you for joining us again. We're going to sign off. Be safe. We'll see you soon.
Thanks, everyone.
Bye-bye.
Have a good night or day, Catherine.
Thank you. Thank you.